again. So this is a very old image that you probably know, but takes into consideration the most important things we have to evaluate with imaging after PCI. So the presence of dissection, the presence of residual disease, the presence of tissue protrusion or stent under expansion or malapposition, and also the minimal stent area, which is what we were talking about a few seconds ago. So first of all, and again, we need to have a stepwise approach in order to evaluate all the important things that we need to evaluate. So first of all, we need to evaluate the geographic miss. That means that we didn't catch completely the whole lesion, and also the presence or absence of edge dissections. Then we have to check for malapposition. That means we have more than a lot of struts, let's say, that are not completely opposed to the vessel wall. And then we have to check for the optimal stent expansion, which is a sort of combination between an absolute and relative measures that we can do in our stent after deployment and post-dilatation. So one point is to evaluate the distal landing zone and the presence and measure of plaque burden at the distal part of the stent. So we know that we need to get a good result by covering the lesion with a stent, but it is very difficult to land on a completely healthy vessel. And so we can accept to have a small plaque burden at the edge of the stent. What is different is the presence of edge dissections, because edge dissections are related to stent thrombosis, and we define an edge dissection as all the dissections that occurs within 5 millimeters from the edge of the stent. And what we measure the length of the dissection and also the degree, the arc degree of the dissection. And the magic numbers are 60 degrees as lateral extension, so as arc of dissection, and 2 millimeters as far as the length of the dissection is concerned. And here you can see a pretty small intimal dissection in this situation, and a deeper medial dissection in this situation. So dissection is characterized also, as I was saying, by the depth of dissection. So sometimes we have dissections that are only related to the intimal side. You can see here the intima, which is disrupted, and it's quite often seen also after balloon predilatation of non-calcific lesions when you go with the high atmospheres. And in this case, you can see a medial dissection that extends all the way up to the media. And these dissections are usually more severe and sometimes need a particular treatment to avoid stent failure, acute stent failure. Again, the dissection angle, which is measured, for example, in this case, this is a drawing that explains very well how to measure the flap angle. So moving from where the intima is disrupted until the position where the media is again in a continuous pattern with the intima. And more than 60 degrees can be a predictor of acute stent thrombosis. And also the longitudinal length, again, this can be achieved with automatic pullback. If we have a longitudinal length which is 3 millimeters or more, this can be a predictor of stent thrombosis. We have understood that stent have to be well opposed. This was the experience with the first generation drug-eluting stents. And of course, imaging is I think the only tool that really can tell you if a stent is well opposed or not. And here you can see a clear image of a malopposed stent. You can see this image that looks like a dissection, but it is a side branch. But this is the vessel wall, and this is a very long, in terms of lateral extension, under malapposition of the stent, with a lot of struts that are very far from the vessel wall. So again, we can measure and grade the malapposition in terms of the distance between the stand strut and the vessel wall, and the magic number is 0.5 millimeter, and the length in the longitudinal view, and again we have a magic number that is 1 millimeter. So there's malapposition that have more than 0.5 millimeters in distance between the stand struts and the vessel wall and are longer than 1 millimeter need a treatment, need to be addressed. Tissue can protrude from a stand. This is not always useful because sometimes tissue protrusion cannot be really addressed with a specific treatment. This happens more frequently with soft plaques, and more frequently in the setting of an acute coronary syndrome when we have atherothrombotic plaques, and much more than in calcific situations. But again, imaging can help you to understand if you have protrusion just after stent deployment and post-dilatation, and in some cases you have to address treatment. So we get to the expansion of the stent, which was the question that our colleague put us a few minutes ago. So what about stent expansion? We may have under expansion of the stent can be measured with an absolute measure. So we need to get a number that says this stent is okay in an absolute way, or we have relative measures that are normalized on the diameters of the vessel, which makes sense, because a big vessel needs, of course, a bigger area than a small vessel. And this is the relative expansion that can be measured on the proximal or on the distal reference diameter, but usually can be measured on the average between the proximal and the distal reference vessel diameter. And we should achieve more than 90%, but then we will see that this is not completely correct. So this is what we say. We have to have a minimal stent area which is more than 90% at the proximal or distal reference lumen area, so we have to compare this area. But sometimes to achieve the 90% we can have problems like perforation, like overexpansion, like dissections at the edge of the stent. So we can accept an area which is more than 80% of the average reference area. So we make the average between the proximal and distal reference areas, and we need to achieve more than 80%. And this is a very simple table that tells you which is the theoretical result after balloon dilatation with different sizes. For example, a 3.5 is 9.62, and the target is 80%. Let's say this is 10. Our 80% is 8 square millimeters. This is particularly true for the left main lesions. You know that there was a study from the East Asia that set the rule of 5, 6, 7, 8. Now the rule is 6, 7, 10, let's say 6, 7, 11. If we watch the results of the Excel trial, where we saw that the minimal stent area more than 11 square millimeters in the distal left main was associated with almost no adverse events and with 0 acute adverse events like stent thrombosis. So we should achieve at least 1 millimeter square for the distal left main. And again, these are measures of cross-sectional areas of different stents in different vessels. And I think that we can, take as a take-home message 80% or more than 5.5 millimeters square. 5.5 millimeters square comes also from the evaluation of the eccentricity index, because we know that if we have an eccentricity index which is defined as the ratio between the smaller diameter and the bigger diameter of the stent, if this eccentricity index is more than 0.8, we have a better elution of the drug and probably better results. But at the end of the day, it is sometimes very hard to get this eccentricity index. Sometimes we have to accept less than 0.8, and in this case we have to measure the area, and again we can combine an eccentricity index which is less than 0.8 but with a minimal stent area that is more than 5.5 square millimeter. In this case, it is a good result. So this was actually my last slide. So we covered all, I think, the information that we have to cover in terms of stent optimization. And these are the key messages that I give to you. Thank you.